Good morning or good afternoon, depending on where you happen to be in the country. And this is ATOD's second webinar in expanding the use of mobile vans. Our first convened during August of 2021, following the release of the DEA regulations on the mobile vans. And this is a how-to webinar focusing on two programs that have now opened or are about to open vans since the regulations were posted. And it's understood that this is a complex process, and we try to simplify this as best as we can. So, as you see on the screen, it's going to feature speakers who have been involved in setting up these new vans. You're going to get some details on federal guidance from the DEA and SAMHSA in developing such van systems. And there'll be a brief discussion on the cost of purchasing such vans and how programs can go about doing that. And there'll be an update on reimbursement mechanisms to support the use of these vans. And the whole idea here is to push the reach of OTPs out into the community, especially in underserved suburban and rural areas. But another use is working with correctional facilities. And this is, to my way of thinking, a really exciting opportunity. There is real interest in this, and SAMHSA has been working with the Bureau of Prisons in this kind of initiative as well. So the funding for this webinar is made in part through a SAMHSA grant and then through the Opioid Response Network, ORN, and we're very grateful to have that support, obviously. Now, this is more of a technical issue. If you've got problems joining this webinar, you can send an email to Angelina.Budija, Budija, @atod.org, or you call in at 201-218-8030. So I'll say again, it's Angelina.Budija, Budija, @atod.org. And I'm also want to take this time to thank Angelina for helping to coordinate this webinar. So if you're listening to webinars through your computer, check to make sure that your speakers are working and your earphones are all plugged in. And there are two options to join this webinar by way of Zoom. You join through the computer using the link that was provided by the email that you received upon registration. If you want to join by phone, you dial 1-386-347-5053 and you enter 843-437-556294. And then when you're asked to enter the meeting ID number after dialing in. Passcode, as you will see, is 6996777. Okay, so now with those sort of technical issues aside, we anticipate that we will use the time allotted for this presentation. And obviously we're going to hold the questions to the end so that you get the benefit of hearing from the speakers, and then we'll put the questions to them, and so that we will have an informative webinar. And that's the whole point. So now I will not discuss our general policy areas because of limited time. Clearly, this is an incredibly dynamic time in this system. And given my 40-year experience in doing this work, starting in 1974 as a young clinician in a treatment program in New York City, I can't even tell you how much has changed in that 40-year period of time. We started from the Wild West, which is how I would characterize OTPs in the late 60s and 70s, to a more sophisticated system. And so with that, let me introduce Nikita Prince. She's the staff coordinator of the Drug Enforcement Administration Headquarters Diversion Control Division in the Office of Policy Liaison Section. And as of 2023, she is the new staff coordinator assigned to the DEA headquarters. And she's a distinguished graduate of Hampton University with a Bachelor's of Science degree in biology. Ms. Prince recently served as the DEA Diversion Group Supervisor in the Baltimore Field District Office. In the Diversion Group, she completed the basic diversion investigative training at the DEA Training Academy in Quantico, Virginia. And from September 2017 to May 2023, Ms. Prince oversaw diversion operations for the DEA Washington Division, Baltimore District Office, with an area of responsibility that it certainly includes Baltimore City, Baltimore County, and parts of Central Maryland, Western Maryland, and the Maryland Eastern Shore. She's been involved in the development of narcotic treatment program initiatives to bring these programs in compliance with the DEA regulations. And I will say that that's something that's of great interest and value to us, because from our point of view, even in the recently released updated DEA guidelines, that provides guidance to OTPs throughout the country. And even when that was originally published in April of 2000, it created a great opportunity for people to be in increased compliance with the DEA. And from my point of view, the DEA folks have been extremely helpful and flexible. So welcome, Nikita. Thanks for joining us. You've got your 10 minutes or so.
All right, I'm gonna set my timer because sometimes I know I can get to yapping, but thank you, Mark, for the invitation to speak today. I am excited. As Mark stated, I have worked with numerous programs throughout my tenure as a group supervisor in Baltimore. I've had hands-on experience in the field with setting up a few of the vans that are currently operational in that area. I am newly assigned to this unit as of May 22nd. So this is a new position for me. So the questions at the end, if you have anything that I'm unable to answer, I definitely will find the answer and follow up. But hopefully I'll be able to answer the questions. I've had, like I said, a wealth of experience with the narcotic treatment programs, and I'll be referring to them as NTPs throughout the rest of this discussion. On June 28th, 2021, the final rule was published, granting authority to narcotic treatment programs to add a mobile conveyance to the registration without having to apply for a second or an additional registration. And I'll just kind of talk to you about the process and how that works for us on our side of the house with establishing the mobile conveyance. And our goal with the EA, again, is to expand treatment and services. We know that there are a lot of areas that still aren't being reached because of access and lack of access. So we're hoping that these mobile units will expand those services to reach areas, and especially with the correctional facilities as well. I know in the state of Maryland, as of, I think it was January 1st, correct me if I'm wrong, of this year, I believe all of the jails had to have some form of medical assisted treatment program established within their facility. So I know before I left my GS position, there were lots of programs reaching out regarding how they can assist the jail. So this mobile conveyance will be a big help in that area. Generally what happens, again, this isn't a separate registration. You simply request it through your local DEA office, and there are a series of steps that will take place prior to the mobile conveyance becoming operational. On our end, again, you would send a written letter to your local office simply stating, hey, we would like to add a mobile conveyance unit to our registration. The supervisor in that office will assign it to an investigator. The investigator will make contact with the facility, the NTP that made the request, and then set up a connection, to kind of talk through some things on what to expect when the DEA shows up. One of the bigger things to think about when you prepare to establish your mobile conveyance is making sure you have a SOP in place for the mobile conveyance. That's very important in the event, especially in the event that the mobile unit becomes inoperable or anything like that. You want to have a SOP outside of the brick and mortar SOP set up with the mobile conveyance. The mobile conveyance can operate throughout the state that the brick and mortar NTP is located and dispensing in. 1301.72 E1, Title 21, requires that the drugs that are on the mobile van be brought back to the brick and mortar upon the end of the day. However, there is an exception that can be applied for by way of 1301.72 E2, where you can apply to be able to store the drugs on the van overnight in the event that if it's a long distance, so you may not make it back, you can apply for that. That requires an extra step of approval. Our assistant administrator would determine if that will work for that particular request, but the exception is something that can be applied to the registration. Security is very important. When the investigators come out on site, they will inspect the mobile unit, go on and test security, look at the setup, making sure, just like in a brick and mortar, that the dispensing area is separated from the waiting area. And in that event with the mobile unit, if there's not enough room for that to take place, then we want the patients to make sure that they're waiting outside of the van. But generally, again, when we come on site, it is quite a process, a lengthy process in terms of there are a lot of questions that have to be answered, because we have to not only deal with the things that come along with the dispensing and SOP, but we also have to deal with the state and city things that are required for the mobile van in and of itself, making sure that all of the licensures and everything are in place to be able to make it operational. After that takes place, generally it will depend. I can't give a concrete time period of what will happen or how long it would take for the approval to take place. Once that information is brought back, the investigator will do a report. The report is reviewed by upper management. Upper management will then sign off on a letter. That once the facility or the NTP receives the letter, the mobile unit can now become operational. So you cannot become operational until you receive the letter from DEA giving you that approval to become operational. And then just some things to think about. If ever the unit becomes non-operational, you definitely want to reach out to the local office so they can document it. And if you have any questions, your local DEA office is there ready to assist you and help you with any questions or services that you may need relating to that. Because again, DEA's goal is to assist with the expansion of the services throughout the community to make sure that patient care is expanded. There are some other little things. Enrollment in terms of the patients enrolled to the mobile unit. They have to be patients already enrolled to the brick and mortar. Your mobile unit cannot act as a hospital or an emergency vehicle, meaning you can't transport the patients. You can transport the drugs, but not the patients. But again, our hope is that many of you sign up so that these services can be expanded. It's like I said, especially to the correctional facilities and some other facilities that Mark spoke of earlier. I think it is a positive thing. I think, again, it's something that's a long time coming, and we hope that many of you would, take up this opportunity. And thank you.
Well, thank you, Nikita. I know you'll stay with us for the Q&A at the end, but absolutely. I appreciate what you've said. And again, to the providers and state officials that are participating in this webinar, keep in mind that you do need various levels of approval with the State Opioid Treatment Authority, with SAMHSA, and of course with the DEA as well. But it's doable. And that's yes, there are procedures, but it is doable. So if you have an interest, you have to move on that. So now let me introduce Nicole Smith. She's the Regulatory Programs Branch Chief in CSAT's Division of Pharmacologic Therapies. And as the Regulatory Programs Branch Chief, Nicole provides leadership to the staff who oversee over 2,000 opiate treatment programs across the United States. This regulatory programs branch is responsible for administering the day-to-day regulatory oversight activities that are necessary to implement and enforce SAMHSA's OTP's regulations. Nicole's been with SAMHSA for the past 17 years and has worked across functional and programmatic areas, including the Center for Mental Health Services, Mental Health Block Grant and Protection and Advocacy for individuals with mental illness. And then prior to working at SAMHSA, Nicole served as a patient services coordinator at Howard University's Hospital Department of Psychiatry. That experience should prove helpful to you in dealing with the many folks that you do. I'm being kind and diplomatic. So I certainly sympathize with Nicole because overseeing such a network takes enormous discipline and patience. And I know something about that given what I do in my realm. So Nicole, thank you once again for joining us.
Thank you. I appreciate that. Angelina, next slide. I would like to provide everyone with an overview of our division, as well as walk you through the application process. So in our division of pharmacologic therapies, in SAMHSA CSAT, we have 3 main areas of focus: certification and accreditation of opioid treatment programs, provider training and support, as well as implementation of medications for substance use disorders in non-OTP settings. Next slide. With mobile medication units, there are unique opportunities for providing medications for opiate use disorder, such as servicing rural areas and indigent populations, providing medication to patients in jails and prisons through formal agreements, and practitioners prescribing of buprenorphine. Additionally, these units can provide the same services as an OTP, where space allows for quality patient care. Required services not provided at the medication or mobile unit must be conducted at the primary OTP, including medical, counseling, vocational, educational, and other assessment and treatment services. However, as some may have experienced, there are some barriers to adding mobile units, such as state rulemaking, financing. There are funding opportunities through current grants, such as the SAMHSA SOAR and block grants, and additional information is available on our website, samhsa.gov. Another barrier can be distance and location of the patients to where you want to serve, as you have to park at the primary home OTP daily, as well as the patient population not large enough to support the expansion. Next slide. Taking a look at OTPs across the nation, as Mark mentioned, as of this April, we reached the 2,000 mark and now have over 2,000 OTPs. Next slide. And specifically taking a look at mobile medication units across the nation, we currently have 33 mobile units, with an increase of 18 new units since the DEA's updated guidance in 2021. New Jersey and Puerto Rico currently have the most units, with 4 in each state. Next slide. Now I would like to walk you through the SAMHSA application process. The first step for an OTP in applying for a mobile medication unit is to speak with your respective SOTA. Let them know of your interests and plans so that they may explain any state requirements or prohibitions. And next, the program sponsor should log into the OTP extranet and select the SMA 162 tab. Next slide. The first section on the application contains the purpose of the form, and you must choose medication unit in order to populate the current information required for the request. Our brick and mortar and mobile medication unit applications are the same. Question 1 is pre-filled with OTP information and you cannot edit it. Next slide. Questions 2 through 11 are also pre-filled with information stored in the OTP extranet about your program. Please note that because the purpose is medication unit or mobile unit, you cannot change any information about the program sponsor or medical director. from this screen. You must choose a different and separate SMA 162 form for additional change requests. Next slide. The next section is where you complete the information about the med unit. You must choose the purpose of the unit, either daily dosing only or dosing and other required services as space allows. Then you fill in all of the relevant information about the unit. And if it's a mobile unit, you check mobile van. The state section is also unable to be edited, as med units must be located in the same state as the primary OTP. Next slide. Question 13 requires that you enter at least one treatment type and the number of patients receiving that type of treatment. This excludes buprenorphine prescribing. Question 14 is pre-filled with current information about your program. And when you're done, you would click the next button. Next slide. This page indicates required documentation for your medication unit and tabs for uploading each. Let's review the checklist more in depth. Next slide. The application checklist for brick and mortar medication units and mobile units are the same as I mentioned, and we require a description of how the medication unit will receive the medication supply from the primary facility, an affirmative statement that the sponsor agrees to retain responsibility of patient care, a detailed labeled floor plan of the med unit, a written description of the facilities to be used as the med unit. We also request that you provide the total number of patients to be served by the primary facility and mobile unit combined, as well as the total number of patients that will be served only at the med unit. And lastly, the program sponsor will need to provide a brief justification for establishing the unit. Next slide. Mobile unit requests are triplicate and require SAMHSA state and DEA approvals. Please note that the accreditation of the primary OTP will extend to the mobile unit, and the unit will be reviewed during the next scheduled survey cycle. Next slide. Our goal is to make the application process streamlined. Should you incur any issues, feel free to contact our OCP ExtraNet Help Desk or the assigned SAMHSA compliance officer for your state. Next slide. And again, I thank you for the opportunity to review this process, and I welcome any questions at the end. Thanks, Mark.
Okay, thank you, Nicole. And that gives you states and programs a sort of brief but clearly defined approach in how you can get this started. And again, you're going to hear me say this at the end of this as well. It's really important that you begin this process. If you have an interest, and keep in mind during the Q&A section, we can respond to questions about how you finance this, how you obtain the funds to actually get this done. And we will certainly handle this at the conclusion when we get to the Q&A section. Okay, so now let's hear from the providers who ultimately have to go through the process, as both Nikita and Nicole have mentioned. So first we'll turn to Linda Hurley. I'll tell you a few things about Linda. I've known her for many years, clearly. Linda's worked in the substance abuse treatment and behavioral health care field for more than 30 years, and she's been with Kodak in Rhode Island since 1991. She was named Kodak's president, CEO in 2016. And through Ms. Hurley's leadership, Kodak was the first OTP in the nation to receive Health Home certification and the first OTP in Rhode Island to be designated as a center of excellence. Linda established the first of its kind comprehensive medication-assisted treatment program for corrections and a recognized tobacco cessation program. And these have been presentations at our conferences throughout the years. Kodak has been one of the first of the HCV treatment programs embedded in an OTP, and has been a leader working to affect policy change in Rhode Island, serving on numerous boards and coalitions. She's also been called upon as a consultant for state and federal agencies, including SAMHSA and the US Senate. And Senator Whitehouse, one of the great senators from Rhode Island, has worked closely with Linda for years and is acknowledged her unbelievable contributions. And I have to say, Linda's vision for efficient patient-centered care has made Kodak a leader in introducing new best and evidence-based practices in Rhode Island, Massachusetts, and certainly nationally. And I can tell you, when people, especially reporters, ask me to identify a great treatment program, which is comprehensive, hands-on, Kodak comes to mind first. And I will only say that I'm grateful for Linda joining us so that she can walk you through their process in getting a van operated. So, Linda, it is yours. You know, you got 24 minutes as you see fit.
Okay. Thank you. And can you hear me?
Yes.
Oh, yay. All right. And thank you for that lovely introduction, Mark. I'm clearly more project oriented than IT oriented. So thank you for your patience. This is the first of our units, clearly. I just have a few slides here just for you to get a sense of what we have present in these units. They're amazingly compact. There is an exam room, there is a counseling space, there is a dispensary. And, you know, this pretty much speaks to why we decided to do this. You know, we've already spoken about the newest DEA regulations, and we were thrilled to have it happen. I'm not going, you can have a copy of these. And I need to do this, I think. There we are. Okay. So, you know, our goal is always to provide all FDA approved medicines for this disease. And, you know, the longitudinally evidence-based medicines for opioid use disorder, really what is the most effective for chronic use is methadone. To reach populations that are challenged with both geographic and external and internal barriers to care. This is very important. What we saw, and I'm just making sure my time is right here. What we saw over the last few years in Rhode Island and across the country, but is an increase in overdose death, of course. And this overdose death, I have had to respond in certain capacities to taxpayers' questions and policymakers' questions for their constituents. You know, we're dumping all this, and literally the term was dumping all this money into opioid use disorder, and the death rates keep going up. What are you doing wrong? And we're not doing anything wrong. That's the reality. What's happened is the landscape of the disease has shifted. So we did the right things. You know, we got and are getting MOUD integrated into our correctional systems. And that was in Rhode Island, 25% of the people that were suffering from opioid use disorder overdoses or overdose death upon within a short period upon release from correctional care. So that was huge. And 25% of those deaths, we looked at up to 61% of those deaths being diminished. The relative risk percentage was incredible. It never happens in medicine. So we know that we did things right. We know treatment works. So treatment is working for the population in treatment. And, you know, the new programming for MOUD and correctional care is working because the numbers for that population of overdose death are going down. We know that. So what has continued to change or emerge? And what has continued to change or emerge are, of course, the issues with the current product on the street, and, you know, with all the adulterants. And you are all very familiar with those. The other piece is what rose to our attention was access issues. And it's not just access issues in in the rural areas, because even though Rhode Island is, I always say it because it struck me funny when I moved here, but it's like the size of a peanut and it's shaped like a peanut. It's very small, but we still have those issues of access due to geographic issues. But the greater access issues, at least here in Rhode Island, and what I'm learning in my interactions with New York and Philadelphia, is that, you know, the overarching racism that has been embedded into our medical infrastructure has taught many people, people of color, people that are marginalized in general, those systems have taught people that need the care the most, that the care that they're going to get when they come to an institution or a brick and mortar is going to not be effective for them. And they've been taught it generation after generation. So one of our goals is really remarkably important, is to go into communities where there isn't trust of OTPs, where there isn't trust of going to a doctor's office in a brick and mortar, and providing those services. And we are really attempting, and we're being partially successful in creating staffing for that is culturally congruent for them. So, and the third goal is pretty self-explanatory there. I'm going to go through this briefly, and if any of you have questions, I'm happy to answer later. But this is what we have been doing on the mobile unit that's been on the road since last August. In addition to, of course, you know, providing methadone. Target populations, transportation, I spoke to this already. And we found this last bullet is going to encampments to assist people who are without homes has been remarkably important to those individuals and to us and to our staff. I think we have between 66 and 100 folks that come to the unit you saw in the beginning of this, not daily, but they're served daily if they want to be. And it has been, right now we're measuring with the hospital ED in the town of Woonsocket and the FQHC in the town of Woonsocket, the real rates of substance use disorder, opioid use disorder admissions. And we're pretty excited about it because both of those entities say anecdotally that they've seen a considerable decrease since last September. The hotspots are an interesting piece. If in Rhode Island, we work with the Rhode Island Department of Health and our SOTA, the substance, the SOTA out of behavioral health in Rhode Island. And we work with them to identify weekly where the hotspots have been, so that after we provide the dispensing of the medications for opioid use disorder, and we return to the home clinic and transfer the inventory, we then go back out to do all the rest of the things that we can do in terms of outreach. And that has also been remarkably well received. We had warming centers emerge through a great need this last late winter when it was bitterly cold in New England. And we went there in the afternoons and provided wound care and on-demand services that were really lovely. Scheduling, this is all individual. So I just gave this as an example so that you can understand that this is just one way we go where the need is at the time of the need. So it's where the people are and what time they need us. And that is exactly what we do and what you would be looking at doing. Challenges, this is another larger slide. I'll talk a little bit more here, is funding. So we have found that there's two pieces to funding. Funding is for staffing. Once established, is just like having a brick and mortar. Once you get your census, then you can ascertain, you know, how many people you need to see to be able to support the unit. But getting the unit, and our units coming from the entity, the folks that we're buying them from, are run anywhere from, I think they're anywhere from $390 to $435, 390,000 to 425 to 30,000. And that just depends, you know, if you want to have the hydraulic system to get wheelchairs in, that's going to be a considerable cost. Like everything that we add becomes, it's more of a cost. How we were funded by private entity and by the state. For private entity for the first one, and state by the second one. And as more evidence, we're also working with Brown University and have applied for assistance with NIDA to really start to look at MOUD and its efficacy for the neediest of our patients through the flexibility of a mobile unit. So it's exciting. And I think that dollars are going to start to be a little more free as we start to get more true evidence about the success of this. Bottom line, we've already talked about DEA, and what we've learned is that it's really important just to have the DEA be a partner and be a partner from the beginning, because we didn't in the beginning. And I've been around for too many decades, you know, and sometimes I carry nonsense with me. And I think that that was part of my hesitancy to reaching out to our local DEA in the first place, in the very, very beginning. So we got held up. We did get held up. And this is just an example around the safe. And but the most important bullet here is the second one, which is stigma. And I want to share this with you. And Mark or Angelina, I've lost track of time because I'm excited. So can you just tell me when I have 5 minutes left?
Yeah, we'll do it.
Thank you. So on January 2nd, I was coming back from Pennsylvania, and it was a Monday, I believe. And I received in my email a cease and desist order. And the mayor in one of the communities we were serving, one of the neediest with the homeless populations, the encampments, all of this in the cold of January, we received a cease and desist order. And, you know, I'm old, so I've done the same thing for a long time. So, you know, you start to know stuff. It's kind of important. So I know where we were parked, we were zoned correctly. I knew there weren't any permitting issues. It was private property from a community care organization that was excited to have us. And they referenced some type of zoning. And so we got a great deal. This is important to know, because sometimes where we are needed, all the people aren't going to want us. And it needs, just like opening an NTP or an OTP, we have to be very cautious. Not be slow, just be cautious and considerate about how we are integrating with the community. And I was totally blindsided because everyone seemed to want us there. And so we're still there, but there was a huge amount of media focus, and it was difficult because I didn't want to offend some parts of the city leadership that did not want us to be there. So I just kept reassuring people that until someone told us that it was no longer legal for us to be there, we would be there. Don't worry if you get, that type of thing. But that was a big deal. And sometimes, best laid plans, we still get blindsided. And this whole idea of a mobile unit, one of the only concerns I've heard from the individuals utilizing the service there is worry about what happens if you can't be here. What happens if you get a flat tire? What happens if there is a snowstorm? What happens, so when you do your SOPs, your procedures, you lay out very clearly, as you do for your state and for SAMHSA and for DEA, exactly what's going to happen for each of those events. Any event that could keep us from reaching the people that require our services any given day, we have a very defined procedure. And I think that has helped us a great deal. And that was, me being blindsided by the cease and desist order was one of the times that I really relied on my team to look around and say, okay, how are we going to do this? And, we had in 2 days, we had backup plans if the state police had come and made us go. So it's just interesting. We just always have to be prepared. So that's what we learned about the policy and political pieces of introducing this service. What we learned about operational implementation, we wanted to expand the size of the exam room. This was a 27-foot unit and delivered today. And I am so sorry I don't have a video to show you. But delivered today is our 35-foot unit, which is going to give a great deal more privacy for our patients and move patient throughput. We created the exterior and interior seating area in a different way. And we want to reach out. This is just some of our goals, is we want to reach out into more of the encampments. There's not a lot in Rhode Island, but they're there. And so there we are. This is our new one. I don't know if you can see the cursor. Can you see the cursor? No, you probably can't. But to the left, in the back, that area where there's a chair is actually a waiting space for the dispensary or for the exam room, and it allows so much more privacy. And then we have some in the front as well. So take your time and look through this. This is the newer version.
And you've got about 4 or 5 minutes left.
Okie doke. Thanks, Mark. This is just, I'm not here to market for the vendor or partner that has been helping us, but they have been doing a wonderful job. They continue to be, I think we get the unit, the second unit we got within 132 days. They, as other vendors have been doing, they're purchasing used RVs and changing them into whatever, your community or our community sees as a need. There you go. That's the range of cost. I knew it was there somewhere. And I was just talking to them yesterday about the next one, thinking about having 2 dosing windows since we have 2 points of entry. Might be interesting to look at. And, I would suggest, because we've had vendors of all kinds, but if you want to pick a vendor that really does care about what they're doing, this particular group only does mobile medical units. And they're excited about this. I'm not going to go into this in great detail, But for those of you that are looking at doing it, please use this when you talk to your potential vendors or partners. It's just what you need and what you will pay for. So and some, you know, I love the warranty. So this is just an example. It'll be different for all of you because we will all, you know, we all have different staffing configurations, times, who's going to do what function. This was where we started in the beginning. 2 clinicians now have moved to peers and case managers and counselors, depending upon the day and the function and the need for the individuals we're serving. And this is just, you can take your time to look at these, but it's really, really lovely. And our patients feel, they actually said they feel special. You know, it's clean, it's neat, we care. It's very nice. And that is what is going to be pulling into our parking lot at 4 o'clock. I talked about funding, and I really, again, we have gotten earmarks before, but we have been using that for our integrated care unit. So we are, but private funders can really help with something as inexpensive as something that is, you know, under $400,000, as opposed to brick and mortar. And the staffing issues, again, we talked about staffing and needs. I know that we are all faced with workforce shortages. What we have found here in Rhode Island and others that I have talked to have found across the country is that there is not an issue in workforce in doing these units. These units attract people that are excited. We actually had more providers, more docs, not even NPs or PAs, lining up, doing one on Monday. One doc was doing Monday, another was doing Wednesday. We actually had at one point more than we needed. And staffing loves it. You know, it appeals, it's new and it appeals to people that really want to reach with those of us that are the most needy. So that has not been as much of an issue, even though they were a little worried about, you know, what the community approach would be. And lastly, I think where we are going is we're addressing both access issues. So that would, we're planning on doing both rural areas, and we are also planning on working in the urban core areas here in Providence, Pawtucket, Central Falls. So we're excited. We're going to measure what we do, and I am more than happy to talk to you about any of these aspects, or to share staff that can talk to you about IT and hydraulics. And if you're in a cold state, what happens in the winter, because you have to have water in these. Okay, they're the kind of things that you're really going to want to think about, because you have to think about everything in order to create a proposal that to ask for money that's going to give you what you need. And I'm so excited. Thank you for being on.
And thank you, Linda. It's practical and very clear. And for the folks, I know there are questions coming in. I've been reviewing them. Yes, this is being recorded. Yes, participants will get access to the slides and all the information that's been presented. That's the whole point of this, that you're going to get the information. And Linda's said it to you, you know, look at the material. And by all means, you can submit additional questions. Even if they're not answered today, we'll get them to the speakers, and we will ask the speakers to obviously respond, and I'm sure that they will, because that's the whole purpose of doing this. So thanks again, Linda. Let's turn to Rebecca. Rebecca Trott is new to us, courtesy of our colleagues in Maryland. And she's got terrific energy. Obviously, I've had the chance to speak with her. She's the program manager of the Road to Recovery program at the Anne Arundel County Department of Health, located in Annapolis. She oversees programs. There are 3 OTPs, 2 are in the community, and 1 is located in the county's correctional center. Her program is expanding access to treatment through the implementation of the mobile treatment programs. And she also manages the department's Volmobile that currently provides mobile access to low barrier buprenorphine, peer support services, and harm reduction resources. She's a licensed clinical social worker by training, working the behavioral health field since 2015. So Rebecca will guide you through her process.
Thank you so much, Mark. Again, my name is Rebecca Trott, and I'm the program manager for the Road to Recovery program with the Anne Arundel County Department of Health. And I'm going to be talking a little bit about the process of conceptualizing and implementing our mobile narcotic treatment program, which is still in its infancy stage as far as the program is concerned. So I'm just going to talk a little bit about where we are, how we got started, and our process as of today. So just a little bit of background. Anne Arundel County is in Maryland. We're located in close proximity to Baltimore and DC. And the county's made up of relatively diverse communities ranging from urban settings to rural settings. The Road to Recovery program operates under the Anne Arundel County Department of Health's Behavioral Health Bureau. And as Mark discussed, the program consists of 2 community OTPs, one in Annapolis and one in Glen Burnie, Maryland, and then one that operates within the Ordnance Road Correctional Center in Glen Burnie, along with a mobile low threshold buprenorphine program that we already have that operates out of an RV style vehicle. So for us, the discussion of starting a mobile narcotic treatment program started in January of 22, when the Maryland Opioid Operational Command Center announced grant funding opportunities to assist local jurisdictions in meeting the requirements of the Opioid Use Disorder Examination and Treatment Act, or House Bill 116, which requires correctional facilities in the state of Maryland to screen for opioid use disorder and offer all 3 medications for opioid use disorder. Since we already had an established relationship with the Anne Arundel County detention facilities with our opioid treatment program that was already established within the correctional center, they reached out to see how we could work together to assist them in complying with the bill completely. At that time, with our OTP, we were providing methadone and naltrexone to their correctional center, including admissions and making deliveries of methadone to their detention center. So their correctional center is located in the northern end of the county. Their detention center is located in the central part of the county in Annapolis. The needs, the things that we needed to then implement were adding buprenorphine to the mix and then expanding admissions to their detention center in Annapolis, since we were really only providing medication at that time to, and right now, to individuals that were already established in a community program. So we put our heads together and came up with the idea of having a mobile unit operate out of our community clinic, which was already established in Annapolis, which is in very close proximity to the detention center. It would allow us to bring services there, specifically bring admissions there, without having to open up another OTP, which we wanted to avoid doing. In February, we got the ball rolling, began looking at other mobile treatment vans in the area, other local jurisdictions that were using mobile programs for other health services, consulted with the NTP guidelines at that time, and began some initial drafts for the vehicle. This is my lovely draft that I made off, I think, Microsoft paint. I think I'm certainly not an architect, but I knew kind of what I wanted it to look like. And one of the big things that we knew at that time is we wanted to work in a smaller unit. We did not want to venture into getting another RV. So we were looking at how we could implement a program into a cargo van. We submitted our proposal for the grant in March of 2022, and that proposal included the actual vehicle. So it was a Ford Transit cargo van, the mobile medical van customization. We decided at that time that in order to implement this program for the needs that we had, we only really needed to add an additional 2 staff members, which would consist of a full-time counselor and a part-time nurse. And then additional materials, laptops, cell phones, equipment, a new pump, training, all those things that went into it as well. We were approved in June of 22, and then began to work with Tech Ops Specialty Vehicles, which is the company that outfitted our vehicle. We finalized sketches with them, really looked at the placement of where things would go, considering what space would look like, how space needed to be separated, and finalizing initial quotes. So this is started January, started discussions, March submitted a proposal, June we got approval, August we start talking. We didn't get the van until January of 23 is when it's first started getting worked on, which I will get to in a moment. But during this process, there were a lot of considerations that we had to take into play in how things would look, how things would operate. So I'm kind of going to run through a few of them here. Vehicle location. So for us, vehicle we knew was going to be parked at the brick and mortar community clinic, which is very close to the detention center for us. We knew that medication was being taken off daily. And then one thing we did not consider is we needed an electric hookup that we needed to install in order to charge the battery of the vehicle every day. Vehicle type. Like I mentioned before, we already have an RV that requires a significant amount of maintenance, is a very large vehicle. Who can drive it is limited on that vehicle. That's the size. So we knew we wanted to go small. The cargo van really allows for anybody with a license to drive it. It moves around easily. Maintenance is a lot easier with this type of vehicle. And we knew we wanted to go that route. Space. So what services that we were anticipating providing on the vehicle? We knew that the detention center was going to allow us to have some space. However, this vehicle needed to be set up to do those services on the vehicle regardless. So having 2 separate areas, which I'll show a little bit later on, that really lay out a defined medication space and a defined provider space. And then the timeline of production, I think just things to be mindful of, what's available, how long it takes to order things, how long it's going to take the outfitting agency to work through customizing the vehicle, going back and forth, took time, a little bit more than we had anticipated. So January of 23, we started well, I didn't start customizing the vehicle. Tech Ops started customizing the vehicle. And we took a few trips there to look at it, get a sense of changes that we needed. They were extremely, helpful in working through how we wanted it to look, things we wanted to have, bringing in their own ideas of what would work better compared to what we thought initially. And then just a few short weeks ago, we got our completed vehicle, as you can see here. And I am going to go through a little bit more of the specifications of it. So this is the outside of it. It consists of, I don't know if you can see probably not my cursor here, but has an outside charging port that charges the battery, some outside electric outlets if needed, And then an awning if we want to expand or have any kind of outside waiting space. We don't anticipate using that at the detention center, but is a nice added feature if we want. And then this is the first, I'll call half of the vehicle, which is our counseling and provider space. So you can see at the front, the passenger seat can flip around completely and has a desk attached to the seat, as well as a additional space for patients to sit and another workstation for a provider or counselor to sit at. This first picture on your left shows the layout of the vehicle if you're standing at the front and heading back. So you can see our medication space in the back of the vehicle, and there is a sliding pocket door that locks and separates the space when in use. Next slide. This is the medication space. So in this first image, you can see the sliding door locked and the visual from the back of the vehicle, so in the medication space, as well as what it looks like from the back outside of the vehicle if the back doors are unlocked. As you can see, we have our safe that's been bolted to the unit right there. And then the last thing I wanted to show is our dosing window. So like I said, this door is a pocket style door that slides into the vehicle and then locks in place. And this mechanism was something that Tech Ops created to have a locking feature to the pass-through. And that door locks into place from inside the medication space. We're, as I noted, really still in our infancy stage of the program. We actually have the DEA scheduled to come out tomorrow to inspect the vehicles. So we are going to be working closely with them to make any adjustments to operations. And if anybody has any questions, please feel free to reach out.
Thank you, Rebecca. And I can tell you people have lots of questions because I've been reviewing them during the presentation. So we're probably going to go right through 2 o'clock. That's why we apportioned this time. The questions are very specific in certain cases, which means short answers are better. And then there are broader questions. And I'll let you know specifically where the questions are going to each of you, because the questions do cover ranges of all the things you talked about. So this is the time when people want to know. So there's one question for Linda. They would like to know the name of the mobile vendor, and you're free to say it. It's okay.
There we go. Yeah, it is. I always get my M's mixed up. Mission Mobile Medical. They're from North Carolina. And if you have an interest, I can't recommend them enough. They have been remarkable, timely, thoughtful, really paying attention to what our needs are. And basically, I found them to be a great working unit themselves. So.
And there's another question. Again, I'll start with the brief, more practical ones. So based on the size of the mobile unit, does it require a specific driver's license type, or is that a state-to-state type of thing? So both Linda and Rebecca.
Well, the long ones require a CDL. CDL, is it? Yeah, it's a CDL license. We have one smaller unit that we don't use for dosing, a little bit similar to Rebecca's, that didn't require it.
And Rebecca?
Yeah, I would say same for us. That's why we went for the smaller units. CDL will be required for a larger, like RV style vehicle, and our unit does not require them.
Okay, is there any issue, this again for Linda and Rebecca, with regards to the van being located next to a school? I know that's an issue with regard to bricks and mortar facilities, but have you encountered that with the mobile units?
I know I can't speak to that. We haven't
Oh.
encountered this.
Again, talk about the cease and desist. The community care organization that in whose parking lot we were parked is also adjacent to a school. And that apparently, there's nothing legal in Rhode Island. There's nothing anywhere that says you can't be close to a school. But that was apparently what was behind the cease and desist order in the first place. But again, that's one of those more subtle political things, not necessarily stated.
There are a lot of subtle things that aren't necessarily stated in general. Now, this is both for Nicole and Nikita. This is about boards of pharmacy, so I'll give you one of them. We're beginning MOUD treatment mobile units, but a board of pharmacy will not approve us to dispense any medications from the mobile unit. We're only allowed to prescribe, not dispense. So what guidance can you provide?
So unless I missed this, is this for buprenorphine only? Or,
They don't specify, they just talk in general about dispensing medications.
so in general, I know our regional administrator for West Virginia, the SAMHSA regional administrator, Jean Bennett, has been working diligently in that state to get more access to medications for opiate use disorders. And her contact information is actually on our website. It's a question you could pose to her, as I think she would have specific guidance on that issue. And then it's just not totally clear whether this person is specifically asking to use the mobile unit to prescribe, meaning you're going to give prescriptions to patients, or if they're trying to dispense it from the mobile van. If they're trying to dispense it from the mobile van, that's what Jean Bennett has been working towards, having more of that in West Virginia.
Okay. Here's another one, again, Nicole, Nikita. Did I understand correctly that we have to admit people at the OTP before we can serve them in the mobile unit? And even if we have the ability to do intake admissions at the van?
That is a question that I'm definitely going to have to follow up on. I don't know, Nicole, as far as SAMHSA, is there guidance regarding the intake with the mobile unit?
Sure. So the primary OTP is ultimately responsible for all patients, but where space allows, if you mark it on your application, you can perform inductions on the mobile unit. But that patient is considered a patient of the primary OTP because there's only one certification and one DEA registration for those activities. Does that answer it, Mark, or is there additional information needed?
No, I think that's it. That's the primary question.
Okay.
Next, again, is for any of you. Is there an accreditation requirement for mobile medication units? Does the Joint Commission or CARF have separate standards for these particular units? And if not, does the accreditation for standalone OTPs is sufficient and extends to the mobile unit?
So I can jump in on that one. As I indicated, the primary OTP's accreditation will extend to the mobile unit. And when the accreditation timeframe for the survey is up for the primary program, the mobile unit will be reviewed as well. The standards relevant to 42 CFR Part 8 are the same for any medication unit as well as a primary OTP. And it's the expectation that the accrediting body will visit the mobile unit when they perform their on-site survey of the primary OTP. And if for some reason it's a virtual review, pictures and video footage potentially of the mobile unit would be included in that virtual review.
Okay, quick question for Rebecca. Could you state again the vendor you used for your unit?
Yep, it's Tech Ops Specialty Vehicles. And
Okay.
located in Maryland.
And another question, again, this will be to, I think primarily Nicole and Nikita. What are the requirements for storing the RV when not in use? And can it be stored in a secure area off-site?
Yes, in terms of storage, it can be stored if it's, again, it all plays a role into if the drugs are left on the van overnight and if they return to the brick and mortar. If they return to the brick and mortar, it's just a secure, a secure area. The mobile unit should be equipped with an alarm system. If necessary, depending on the area or the location of the brick and mortar, it may require a fenced in area. But that all will depend on, location and when the investigators go out and look at the location. If the drugs are left overnight, there are some extra requirements that would take place for it to be in a secure area. It might have to be stored maybe at if it's at maybe a local health department or a police department parking lot that has the ability to be in a fenced area in that location. But that, again, that would be something that would depend on if the drugs are stored on the facility, on the mobile unit. But more than likely, it's just a matter of it being stored at the brick and mortar location.
Okay, this is going to be for Linda and Rebecca. I know you've alluded to this in your discussions, so this boils down to something more concrete about timing. How long does the process take to establish a mobile medication unit? If we have full funding for it, is it realistic to believe that an established OTP could have the mobile unit up and running by the end of the current calendar year?
Our experience for just having two, and they were pretty extensive projects, would absolutely be. So 150, 160 days, those are usually 130. But there's so many variables. So Rebecca, you can.
Yeah, I was gonna say, I know for us, once the vehicle was in the hands of the of Tech Ops, it only took a couple of months for it to be done. I think they were really done earlier. We just had to wrap the vehicle, took some time. And so I can't speak to the process after that, but at this point, but certainly just getting the vehicle modified, it did not take all that long.
And I would just like to say again that it's really important to work with your local DEA from the beginning, because we had a 6-month delay over a safe, and it was really silly, and it could have been avoided had we really engaged early on. So, my experience is that, yes, there can be some complications and challenges in working with the DEA. But for me, it was more how it varied from region to region. So just embrace your region and go for it from the very beginning.
Well, I would add to that the State Alcohol and Drug Abuse Division and the State Opioid Treatment Authority. I think, this is part and parcel of a sense of having everybody on board. And I absolutely, in my own experience as a treatment provider in New York, I found that too. You absolutely have to work with state officials, local DEA officials, and also with SAMHSA, because they will be helpful. There are absolutely challenges along the way. There's no question about this, but that's part and parcel of this. And DEA has simplified the system. I think that, when you get into having OTPs in jails, and this has come up not in this forum, but there's been a question of how do you simplify the process of setting up OTPs in jail spaces in particular. That seems to be a developing issue. And we'll cover that again in a separate policy discussion. So I think this is mostly to you, Nicole, which is any suggestions on how to encourage SOTAs to approve methadone mobile vans?
Connect with them regularly. Usually there's only a prohibition if there's a state rulemaking that prohibits the expansion. And from my experience, most of the SOTAs that do have those issues are working diligently with their legislature to get those provisions updated and amended to support the operation. And contact us if there's anything we can do to assist, but we do meet with the SOTAs regularly to discuss expansion and options with mobile components and the benefits. And will continue to encourage the expansion across the nation.
And as I mentioned earlier, NASADED, as one of our major policy partners, is planning to convene a webinar before the summer is out, specifically for state alcohol and drug abuse directors and SOTAs, to sort of encourage this, get a sense of where there are barriers, where there are difficulties. So you may be asked further questions by them. But obviously, given what we're trying to do throughout this country and expand access to care, from our association's point of view, this provides, no pun intended, a vehicle to get this accomplished, and that's important. A practical question for Linda and Rebecca. What about parking the vehicle? Is securing methadone if you don't have parking space near your brick and mortar dosing site? And what's your process for loading and unloading the medications per the DEA guidance, including documentation?
Well, since we've been doing it since, I guess, September, we do have parking. We have parking close to the building. We have a parking lot. So so maybe the unit is parked a fifth of a block away in the parking lot. And the inventory is transported to and from every day in a locked facility, in a locked container, and it is transported by nurse and security, and that has been approved. Every aspect of what we're doing has been approved by local DEA.
And to continue this, again, for the providers, but obviously, Nikita, you can jump in as you see. What type of security alarm systems are being used? Is there a contact alarm on doors and on the safe?
Yes, in terms of storage, you can go to Title 21, 1301.72A1 for some specifics regarding the storage and requirements for storage. But yes, contact switch on the safe, very much like you would have security to some extent in the brick and mortar. You'll have it in the mobile unit, any panic switches, and to speak to a specific alarm, I don't have any specific examples to provide. Linda or Rebecca may be able to provide some specific alarm examples, but you do need the alarm, you do need the proper storage, the proper safe, and again, contact switches, all of those things that, the layers of security.
Okay. Now to a list of fairly concrete questions. Regarding the mobile vans with restrooms, what are the regulations for waste dumping procedures? And I would imagine that varies state by state. So Linda?
When I just referenced the issue around water, and particularly for those of us that live in the north and the east or northeast and the north part of the country where it freezes. Okay, it's absolutely critical. I just need to reinforce, and that needs to be in your proposal. It needs to be part of everything that you create for this. People need to wash their hands. They need to use the restroom. The dispensary has to have a sink. All of those things have to happen. And I don't know the specific procedure, but I do know that all wastewater is removed from the unit and taken to wherever it is that it goes, and it's removed every day. And it's really important. Also, I've come to learn, and those of you that are on this call that are much more technologically savvy than I am about anything, is that it also needs to be flushed frequently, not just the toilet, the system. So.
Okay, this is a question for either Rebecca or Linda. Did you notify the DEA of your intent to start a mobile unit prior to starting your design and purchasing of the vehicle? Or did you wait until after you designed and purchased the vehicle to communicate with the DEA? That's an important procedural question.
We waited. And as I said earlier, that was a mistake. That's why I was talking about, if you don't want to lose time and you really just bring your local DEA in as your partner. And I'm sure that they want to be helpful. I know that the kid is nodding, but they do. And that was my call and it was my mistake. So I want to say that strongly because it wastes time. And every time we waste time, there are more lethal drugs being utilized out there. So for every 6 months I wasted, somebody may very well have died or more. I feel strongly about that.
And I think DA was our first call, our first meeting was talking about it before we even submitted a proposal, was talking through, going through those guidelines, kind of really clearly laying out what we needed to do, what it would look like. And we've been in communication ever since. And I know I can email, call anytime and speak with them. So it's extremely helpful and supportive in this.
Absolutely. I, concur again, the sooner the better. I think I worked with Rebecca before leaving, so they were very diligent about, showing the plans of the van, asking a lot of questions. So it is definitely important to on the front end start working things out rather than the back end.
Okay, another question. This is going to be for you, Nikita. I was unaware that there were options for storage of medication aside from returning to the primary OTP and returning the medication to the primary safe with the OTP. So Nikita, can you elaborate a bit on this?
Yes, 1301.72E1 is the regulation that requires the drugs to be brought back to the brick and mortar. However, 1301.72E2 gives the facility the option to apply for what's called an exception to not bring the drugs back. Let's say in a situation where they have to travel, a long distance and can't get back in time, they can apply for the exception. Again, that's something that requires an additional level of approval. The assistant administrator will review the request and decide whether or not that request, meets the need of that particular program. And in that event, I spoke to the storage of that mobile van would require, it to be stored at a secure location outside of the, the registered location, since it will be off-site.
Right, and by the way, this is a practical application. I mean, when the regulations were published, this provision was in place so that if it's not practical for the van based on geography, that it can be permitted not to return to the program. So again, it's a practical matter. Obviously, if a van is traveling a number of miles in that day, and it's just not practical for the van to return, you have to store it in a secured area, and we've already covered some of that. Okay, this one's for you, Nicole. Can we ask SAMHSA to approve Saturday and Sunday take-home doses for all patients served by the unit if we only operate the mobile van Monday through Friday?
Interesting question. I would say with our current take-home flexibilities, the patient should be deemed eligible for the take-home provided. We don't provide blanket take-home exceptions for mobile units. The expectation would be that the patients that are not deemed eligible enough to have the take-homes would report to the primary OTP for dosing. But with the current flexibilities, I don't see it being a problem for the mobile unit to have days where they don't have any patients to treat.
Okay. And again, at a sort of practical level, this is, I think, mostly for Linda and Rebecca. I know that Rebecca, your unit's about to start. So some brick and mortar units retain security guards to be present during dosing hours. Are any of the units using security personnel, and how are you handling security during the hours of operation?
We actually have the same security company that provides security for our mobile, for our brick and mortar, come to the sites where we would dose. And they, you know, they bring their car and they take care of the external part of, say, the parking lots we're in, watch for concerns and get help from staff if there is a problem. I have to tell you that the people that we serve right now are some of have the highest levels of comorbidities I think I've ever seen, in terms of not being institutionalized really. And we're not having any of those issues. It's just amazing how really grateful that people are to be able to have their medicine and the care come to them. So that's what we do. We purchase external good security, as trained as we can possibly get to understand the individuals that we serve that come to us for care. And we do that every day that we are out.
And for us, I think just this is unique to our program where the vehicle's going directly to a detention center. So we'll have security at our brick and mortar that is there all the time. And then they're going right on the yard at the detention center, in which it'll be fenced in with officers present. So we won't have additional security there at the detention center.
I guess this question is going to be for Nicole and Nikita. Will OTP mobile units be required to still be tied to a permanent brick and mortar location?
Under the current regulation, yes, that's a requirement.
Question for Linda and Rebecca. How is counseling provided to the patients at the mobile unit? And is that required?
I'll just go first because I'm wasting time. We're being polite. the, it is still a requirement. Wherever you get your medicine, you have to get the, the entire treatment episode, and we firmly believe in that. So, and everyone is going to be a little bit different. We're not requiring people to come back to the brick and mortar. Most of our folks don't even have transportation, and they would have to take 2 buses to get back to a brick and mortar to do it at any of our sites. So we have 2 spaces inside the vehicle that can be used. They're small, but they work. So if someone is capable of being in that type of closed area, they can. And we also have the community mental health organization or the community care organization right there, adjacent, right next to the parking lot. And they would allow us to have space if we needed space for crisis intervention or other counseling services. At this point, one of the reasons we wanted a larger unit was because if we get to over 100 patients, we know that we're going to need to have more than 2 people on the unit at a time, and it needs to be in a confidential and safe place.
So,
So I was
I'm sorry,
just,
go ahead.
for us, the detention center has allowed us to have space there. We have the space set up in the mobile unit, but we intend to use their space for doing things like collecting urine screens, being able to have a larger counseling space and provider space as needed as well.
Okay, this is a question for Nicole. We are hoping to open a medication unit, serve a rural area about 20 miles away from the brick and mortar OTP. We do not know how many patients will be served by the mobile unit. In the application, should we give our best guess?
Yes, please provide your best estimate for the number of patients that you'll serve.
And for Nikita, there's a question of what type of record keeping does the DEA require in the operation of these mobile vans, moving control 2 and control 3 from the OTP, loading on the van, then unloading the van and moving medication for overnight storage back to the OTP?
The required record keeping that ties into the brick and mortar is required for the mobile unit. So, you're required the initial and what you dispense for the day and return. So it's the same record keeping procedures really tied into the brick and mortar.
Okay, and for Linda and Rebecca, can you identify the safe vendors that you used and experience? So, which safe people did you use?
Honestly, I can't remember, and I don't have it on my PowerPoint, but I'm happy to provide that information for you. I'll send it to Angelina. And the experience, they were fine, but when we were doing this, it was just, we were still a little bit COVID-y, and it was, I just made that word up, COVID-y. And so there were a lot of supply chain issues. It's really, that again, I can't say enough how important it is to work out the highly important specificity or specific pieces with the DEA in particular at the very beginning, because again, it would have saved us many months. So that's our experience. They were just fine, and they brought it, they brought it to us, and they did everything they could possibly do. There were just supply chain demands or supply chain delays that were real barriers.
The same thing for us. It was, I think we picked one safe and they had to find another safe midway through. The tech ops was the one that was helpful in purchasing and coordinating that. So happy to share that information. Just gotta look back and find it as well.
And I recall that the manufacturer of the mobile van had to reinforce chassis to support the weight of the safe units. Is that correct? You're on mute.
Yeah. What ended up happening, I didn't know, I didn't want to take up too much time. We ordered a safe that met all the specifications. And then when the safe was there, and I think it came from New Jersey, when the safe was there, they sent us all the parameters about it. And then they started talking to Mission Medical Mobile, and the mobile unit couldn't support it. So that's when we had to have one actually built. And I think at this point, I don't think that, I don't know if they still have to be built. I mean, we had already purchased the unit. So if you purchase a mobile medical unit that can support 1,000 pounds, then that's fine. But this is all the stuff that, you know, Rebecca, you and your organization did so much more brilliantly than we did. And so that's exactly what happened. And again, the safe company was great. It's like, okay, so you made this mistake, so we'll take this back and we're going to have to make you a new one. Just learning.
A question for, I believe it's Lyndon Rebecca. In inner cities, what types of safety plans have programs been able to develop? While police and public safety is supportive, they do not have the capacity to be present while the mobile access vehicle is at its sites. So safety plans.
I'm not going to be able to recollect the detail of our SOPs for that, but we have, again, we created them for all different types of situations. So that, and really, you know, in response to regulation, but also in response to our own need to provide the best care safely. So we work closely with police and fire in all of our, so we're in 9 communities in Rhode Island. Only 2 with the mobile units right now. But, and that's really, we just keep a relationship going. And, you know, the police may stop by, unlike for me, the old days, the police stop by just to say hi and do you need anything, as opposed to trying to catch somebody with a warrant kind of thing, you know, I'm just way too old. But, so it's developing a relationship with them.
Thank you. And this is for Nicole. If the van owner is not the treatment provider, does the van owner need to complete the SAMHSA form that you reviewed?
So the van owner would need to enter into a formal written agreement with the program sponsor of the primary OTP. And then the program sponsor would submit the form to SAMHSA to request the mobile van.
Okay. So to Linda and Rebecca, how did you go about securing a place to park the van?
We have a parking lot next to our brick and mortar, to which the mobile unit is associated. So that was not difficult. And when I spoke to our colleagues across the state, we have an organization, it's the Leadership Council for Substance Use and Mental Health. Many people asked for us to come to them. And we worked with our SOTA and our Department of Health to choose the spot that was most in need, because we actually had so many people inviting us to park. So I don't know if the park is about parking to provide service or parking, you know, when the van is not in use. So when it's not in use, we have our own property that it is safe on. there were issues. And they just needed to be talked through, but there were some considerable issues around what we had to do to that parking lot to keep the unit safe, even when it didn't have inventory in it. But again, just speaking with your local DEA can work that out before it becomes a big issue.
Well,
And that
in
is it.
general, I think a reasonable point of view would be any OTP that actually purchased the van, is operating it, has a vested interest in protecting its security. If you're
Yes,
talking about a $400,000 investment, whether that investment is coming from private funds or through SAMHSA, the state alcohol and drug abuse agencies, if I'm operating the van, I don't want anybody taking it or doing damage to it. I mean, there's a real practical reality to this sort of thing, I think. This is in general for the providers, and it's about really if something happens to the van, there's a breakdown, or if there's bad weather. In other words, the van is not capable of reaching out and getting to the sites that it's been dealing with. What is it that you do? Do you have a backup van, or how is it that you deal with such emergencies?
That was the primary question that individuals asked us coming to us for care was, what's going to happen if it snows? What's going to happen if there's ice? What's going to happen if you have a flat tire? So we have, again, I'm not going to get into all of the procedures because it would take maybe a half hour, but we have a backup unit. It is not a unit that is, well, at this point, we just got a second one. So I don't know what our schedule is going to be. But we have a unit that would come out and, this is the worst case scenario, would come out, take the medication to the community care organization where the parking lot is, where we would have been parked, and be able to dispense from their dispensary. And that all has to be worked out again with the DEA and with the state to make, for that. Anything else, when it's going to snow, we know ahead of time now, and we really do. So we've been giving take homes to individuals that so far there's been no adverse any outcomes to that. And we also, we had to get some maintenance done, and we had to give take homes. We had one experience with requiring that about 10 people without homes, without cars, we had to require that 10 people take 2 buses, one of them 3 buses, to get to our closest brick and mortar. Not one showed for their medicine. So this is a very real issue that we're talking about locally, to measure the risk, really measure the risk. And the risk, if somebody goes into withdrawal, what are they going to purchase on the street that they might not be alive tomorrow? So.
All right, question about dosing. Does the OTP physician determine the initial dose and dose changes on the mobile van, or is that something that the mobile van can do?
So regardless of location, whether it's a medication mobile unit or a primary OTP, a qualified practitioner would be the person to amend a dose. So that would be a program physician, medical director, or a nurse practitioner or physician assistant with a mid-level practitioner exemption on record.
Okay, this is now a question for the providers, primarily Linda, because she's operating. If there is a line of patients waiting to get access to the van, what do you do in bad weather?
We did 2 things. Actually, there's such a tremendous sense of ownership when we provide care in a way that people really want and need and feel heard, that individuals, we talked a little bit about when you were coming so that they were more spread out over time. That's harder to do for individuals, that, again, primarily don't have homes, as opposed to figuring out in a brick and mortar where people can go and what time they can come in. But people really, really do self-manage well with this. But we got authorization to have waiting space in the community healthcare or the community mental health organization that hosted us, so that people could wait there. And we also looked into getting a tent that could be heated on the outside of the vehicle.
Okay. Nicole, this is for you. Does SAMHSA expect to have mobile units in all states? And if that is so, what mechanism do you have in place to implement such a strategy? Obviously, it means working with the states, but it's a question.
Well, yes, overall, yes, we would love for there to be mobile components available across the US. And we meet with the state opioid treatment authorities regularly to discuss any prohibitions and opportunities for expansion.
Okay, this is for Linda primarily, since you've had an operating van. Can you provide the audience with maintenance schedule and maintenance related costs? Look at it at an annualized basis.
I can actually, and I did not put it in the PowerPoint, but I made up 2 slides. So would you, let's see here. I think I broke it down into monthly because we had 10 months of, may I just send that to you?
Yes.
And we can send it out.
Yes.
Yeah. But it's done. So I can
Yes.
absolutely do that.
Okay. Nikita, this is for you. Does the DEA have requirements or standards regarding where the van can be parked at the clinic? And what, if anything, needs to be around the van? Fencing or other types of parking enclosures? And what are those standards and requirements?
Yeah, I think it's, again, tailored to the facility, the program that's already established. Again, DEA, by way of regulations, can, ask for extra layers of security if deemed necessary. But generally, if it's located on the lot of the NTP, it could be fenced in, not fenced in. But again, having the security established on the mobile van hopefully will deter, any sort of theft or anything like that. But we don't really get in the weeds of the specifics of where in the instance of it returning to the brick and mortar.
And to Linda, did you have any problems in insuring the van?
No. And if I can also send some details about that if anybody has an interest. But there was no problems in insuring the van, the mobile unit. As the units get bigger and bigger, your cost is going to go up, or whatever the liabilities are going to be, or it's going to be reflected in your premiums. But yeah, there was no problem at all.
And then there's another question. I think this is for you, Nicole. The provider wants to collaborate and share ideas with other mobile units. Is it possible to get a directory of the mobile units that are in existence? And will you be publishing that on a SAMHSA directory?
We are exploring publishing medication units in general. So that would be brick and mortar and mobile components on the directory. And I can provide Angelina a list of the OTPs who have an affiliated mobile component. The program sponsor and contact information would be the same, as that's who would be responsible for any collaborations. So I'll send a list of the primary OTPs that have mobile components across the nation.
Okay. And to Linda, for the smaller mobile unit, and if there's if the smaller unit is without a waiting area, is there a separate place from the dispensing area to set up a waiting area outside of the van?
That is sort of, there is a separate area outside of the unit that it has an awning, and it has, you know, we have the video screen that we play videos on. So when the weather isn't inclement, it is that's where people will wait. Very often people will wait in cars. And again, if the weather is very severe, then we can also utilize the organization that hosts us.
Okay. There's a question. Are security guards required to be watching the van, securing the van?
No, as far as DEA is concerned, no, we don't have a regulation requiring that. Again, I think that is to the discretion of the program, as you stated before. You know how much money is being spent. If you feel that, you know, that area would be deemed good to have a 24-hour security, then, you know, that's, you know, up to the program.
Okay. I know there are a couple of questions that are being submitted, and we will get that to you, because in the interests of time, and we are about to end this 2-hour webinar, I think that from my point of view, this has been extremely helpful. I don't think we've had so many questions put to us during any prior webinar that we have done. So I think that reflects an interest, obviously, in this area. So I think that from my point of view, I'm very grateful to all of our speakers for being here, making their presentations and responding to your questions. And again, I am grateful to SAMHSA and the ORN network for funding this. And clearly, we will get questions again to all of our speakers, especially the ones that we were not able to get to. And also, please do keep in mind that all of this has been recorded. The recording will be sent to all participants, and I believe that certificates of participation will also be sent as well. So there is a brief survey that will follow this conclusion, and I'm asking you to respond to that survey, because that's how we, you know, plan ahead for the future. From our point of view, and in wrapping up, the mobile vans are a feature that we think will extend the reach of the OTPs. We've talked about that during the course of this webinar. And yes, the DEA and SAMHSA are partners in this process, which means that as issues come up, as the vans are expanded through the country, remember, this is all part and parcel of having experience. This is relatively new territory in terms of expansion. I know that there are other plans to expand access to care. From our point of view, the care should respond to the presenting needs of the patients. I think we need to be careful about turning our system of care into a medication-only approach to treating a very complicated illness. And this is our association's point of view. It's been our point of view since the association was founded in 1984. So again, I thank people. I want to also thank Angelina Budia, our coordinator, for managing these webinars, because we can't do this without her help and guidance. So thank you again. I hope you've had a chance to enjoy this webinar. I think based on the questions you asked and the answers you got, and I will be candid in saying I was not aware of some of these responses. So thank you again to all of our speakers. And I really found this to be quite interesting. And thanks again. So to everybody, be safe, be healthy, and obviously you will be able to send in other questions if you have it. And I promise we will absolutely get them to all of our speakers. So thanks again. Be well.